Hello everyone, I'm Dr. Mohit Kapoor. I'm a junior resident at Department of Radiodiagnosis, Aiims Bibinagar, Hyderabad. And today, in this lecture, I'm going to discuss first a clinical case with you, and second, I'm going to discuss ultrasound BIRADS. So, starting with the clinical case first. So, this was a case of a 60-year-old female presenting with complaint of a breast lump in left breast, and she was referred to us by surgery department for ultrasound of her breast and review her mammography report. So starting first with the ultrasound, it was done on 19th of April 2023, and finding which we can see here is in this sonography image we can see a large irregular mixed solid and cystic mass lesion, and we can see this solid component here. This is the mural nodule and this is the cystic part. So this is a mixed solid cystic lesion, large irregular, and it is more wider than taller. That is, it has a parallel orientation, and it measures around approximately 8.6 into 5 centimeters. And further, it was noted involving the lower quadrants of the left breast, approximately 7 o'clock to 4 o'clock position. Now, if we see, we can see the outer wall of the lesion at the site of solid component is little ill-defined. We can also find some calcification within the lesion, and we can also find some debris deposition in the lesion also. Further, we put on color Doppler and we could see there was increased vascularity within the lesion, and RI came around 0.7. Then we could also find an enlarged axillary lymph node, and we can see this was the large axillary lymph node. This was the fatty hilum. This was the cortical thickening, and we can see that there was increased cortical thickening. There was increased eccentric cortical thickening, and it measures around 4 mm. So, seeing all these features, the impression which we gave was this was a mixed solid cystic lesion, most likely going in favor of a BIRADS 4 C category. Then we also have mammography report, and it was done on 20th April 2023, and we can see this is the left CCV, left clinical view, and in this we can find a large, well circumscribed hyperdense lesion. And the thing is, mammography is just X-ray beams, so it cannot differentiate between solid and a liquid component. So we can find just a hyperdense lesion. We cannot see if it's solid or liquid, which we can see very clearly on ultrasound. And further, if we see on MLO view, we can find some axillary lymphadenopathy also. So mammography is not very good to see the appearance of the lesion. For that, ultrasound is preferred. But mammography can find even very small lesion which we might miss on ultrasound. So mammography is the initial screening modality for breast lumps, and further ultrasound is used to characterize those lesions. The impression which we gave after the mammography report was it was a BIRADS 4 lesion, and we advise patient to go for biopsy, and on seeing the biopsy report, further follow-up will be done accordingly. So this was a clinical case which I wanted to discuss with you. Now coming to BIRADS. So we have three main modalities. We have mammography, we have ultrasound, we have MRI for breast lumps, and we have various features on all of these modalities. And we have BIRADS category for mammo, ultrasound, mammography, ultrasound, and magnetic MRI. But for the sake of this discussion, we are just going to study ultrasound BIRADS categories. And given depending on the features which you see here, we characterize the breast lump or breast lesion into category 0 to category 6. So starting with the BIRADS ultrasound, first we are going to study tissue composition, then we are going to study mass description, then we are going to study calcifications, associated features, and special cases. Starting first with the tissue composition. So tissue composition, it refers to the echogenicity of the background parenchyma using fat as a reference. So it could be homogeneous fatty like here, it could be fibroglandular like this one, or it could be heterogeneous, that is mix of fibroglandular and fatty. Then mass description. So we have mass distribution in the form of shape, orientation, margin, echo pattern, and posterior features. Starting first with the shape. So shape can be oval shape like here in these images. It could be oval. If the lesion has 2 to 3 lobulation also, then also it will be considered oval. Like here we have some lobulation also. but it's less than 3, so we will consider it oval only. It could be rounded or it could be irregular. Usually, if a lesion has an irregular shape, it goes more in favor of a malignant lesion, whereas rounded oval usually more goes in favor of a benign lesion. Then we have orientation of the lesion. It refers to orientation of the lesion as compared to background parenchyma. So if a lesion is more wider than taller, like here we can see it's more wider than taller, and so we will say it has a parallel orientation. But if a lesion is more taller than wider, we will say it has a non-parallel orientation. So if a lesion has parallel orientation, goes more in favor of benign, and with non-parallel it goes more favor in malignant lesion. Then coming to the margins could be circumscribed or non-circumscribed. If it's circumscribed margin, then it goes more in favor of benign, and if it's non-circumscribed, it goes more in favor of malignancy. So it could be indistinct, or non-circumscribed margins could be indistinct, it could be microlobulated, it could be angular, or it could be spiculated. Next, coming to echopattern, echopattern can be anechoic, hyperechoic, isoechoic, or hypoechoic, or it could be a heterogeneous lesion, or it could be mixed solid cystic lesion. Usually, a mixed solid cystic lesion or a heterogeneous lesion, in fact isoechoic lesion also, they all goes in favor of a malignant etiology, whereas an anechoic or just hyperechoic, they goes more in favor of benign etiology. Coming to posterior features, it could have a posterior acoustic enhancement, it could have posterior acoustic shadowing, or it could not have any posterior features. So if a lesion has a posterior acoustic shadowing, this goes more in favor of a malignant etiology, and if it has posterior acoustic enhancement and no posterior features, then it goes more likely in favor of a benign etiology. Calcification. So calcification, it could be calcification inside the mass, calcification outside the mass, or calcification in intraductal areas. So calcification, if we find calcification within the lesion, it goes more in favor of a malignant etiology. Coming to various associative features, so starting first with the architectural distortion. Architectural distortion means if there is a lesion which will either push or pull the surrounding tissue. Like you can see, it is pushing the surrounding tissue. Here also the lesion is pushing the surrounding tissue. So it will describe this as arterial distortion, and this goes more toward the malignant etiology. Duct changes, it could be form of ductal ectasia, like this one. We can have ductal ectasia. We could have skin changes in the form of skin thickening, skin retraction, or we could have subcutaneous edema also. Edema in whole is a different category also. Previously we used to just describe this as a white halo surrounding the lesion, but now we just describe this as we can describe this as edema surrounding the lesion. Vascularity could be absent. It could be present within the lesion, internal vascularity, or it could be present in the periphery, or also as a rim vascularity. Elasticity assessment is also very important. We do this with help of elastography, and we can say if the lesion is solid, moderate, or hard. So soft, moderate, or hard. If it's a hard lesion, it goes more toward malignant etiology, and it's solid, it goes more toward benign etiology. We have some special cases also. Starting first with the simple cyst. The importance of special cases is that supposedly we have this case. So instead of describing this is as a oval, parallel oriented, circumscribed anechoic lesion with posterior acoustic enhancement, we can just simply describe this as a simple cyst in the ultrasound report. So the importance of special cases is if we find this, we can straightforward describe this by just name and not describe this as a full explanation. So if we find this, we can just straightway say that we find a simple cyst in the breast. We can also have cluster microcyst. Cluster microcyst is we have cluster of tiny anechoic cyst. This cyst will be less than 2 mm in size within the septal area of the breast, and there will be no solid component within the lesion. We can also have complicated cyst. Complicated cyst means a cyst which have some altered texture or some internal echoes. Then it will be called as a complicated cyst. A sebaceous cyst If a simple cyst has a complicated cyst has a tract going towards the skin, then it most likely is a sebaceous cyst. Whereas if a cyst is localized within the epidermis, then it is called as epidermal cyst. We can also have breast implant. It is about to know if the breast implant is intact or there is some extracapsular intracapsular rupture of the breast implant. Now coming to the most important part, that is the what are the characteristic features which suggest that it is a benign lesion or it's a suspicious of malignant lesion. So shape, I told you, if it's oval or round, it's benign. Orientation parallel, benign. Margins circumscribed, benign. Echogenicity anechoic hyperechoic, benign. Posterior acoustic feature, if there is no features or there is some enhancement or some edge shadowing, then it's benign. There should be no calcification. Tissue property should be soft on compression also, soft on elastography also. There should not be any arterial distortion also. Coming to malignant features, so if the shape is irregular, it has non-parallel rotation, it is non-circumscribed, it is iso hyper heterogeneous or mixed solid cystic lesion, it has posterior acoustic shadowing, it has calcification, it is hard lesion, it shows arterial distortion. If we find this features descriptors, then it goes more in favor of a malignant etiology. So on seeing the lesion, seeing how much seeing all the descriptor, if it goes toward benign and malignant, we give BIRADS grading. The grading can be from category 0 to category 6, and starting first with BIRADS category, first starting with category 0. So category 0 is the one where imaging was incomplete and we need more imaging, so that is category 0. Starting with category 1, BIRADS category 1, it is negative, that is there is normal breast tissue, there is no focal lesion seen within the breast. So if we find a patient having absolute normal breast, no focal lesion seen, then it will say it is a BIRADS 1. Coming to this BIRADS 2 category, here we will find a focal lesion, but this is a non-suspicious stable focal lesion. Like this could be a simple cyst, it could be some breast implant, this could be some microcyst. So this all is a focal lesion which are non-suspicious and stable. So this will be BIRADS 2 or benign. Coming to the BIRADS 3, BIRADS 3 includes a complicated cyst or it could include a fibroadenoma. Here the lesion is usually benign only, but there's less than 2% chance that it may go into malignancy also, or it could be malignant also. There's less than 2% chance, then we will give it as BIRADS 3. It's probably benign. So fibroadenoma and complicated cyst. BIRADS 4. BIRADS 4, here we are suspicious that it might be a malignancy. So we have three categories, 4A, 4B and 4C, depending on we have low suspicion, moderate suspicion or high suspicion. And here there is 3% to 95% chance that this lesion might go into malignancy. The thing here is the lesion will have some descriptors which will go in favor of malignancy and some which will go into benign, some description which will go towards benign etiology. So here we have some malignant, some descriptors toward malignancy, some towards benign, and depending on how many descriptors we have towards benign, toward malignant, we can give it 4A, 4B or 4C. And then coming to BIRADS 5, here is more than 95% chance that this lesion will be a malignant on biopsy. So and it has all the classical features, descriptors of malignancy. So this lesion definitely needs biopsy. Then BIRADS 6 is a biopsy proven malignancy. Then we are also going to see about axillary lymph nodes, because we have to see for axillary lymph nodes also. So if we find a small lymph node, small means less than 2 centimeter, which is oval or elongated, which have a thick fatty hilum and cortical rim is thin, less than 2 mm, and we find hilar vascularity, then it's a benign lesion. Instead, if we get a lesion which is longer, it is less oval and more rounded, it has a compressed or smaller fatty hilum and a thicker cortical rim. So if a lesion is more than 3 cm in size, has a cortical rim more than 3 mm in size, then it would most likely be suspicious axillary lymph node, and vascularity is irregular. Then these all features are going towards a suspiciously axillary nodes. So whenever we are doing ultrasound BIRADS, we have to look on breast lesion also, but we have to also look for any lymph node also. And if we find lymph node, we have to characterize this lymph node. It could be benign lymph node or it could be suspicious lymph node. So this was the references which I used to describe all of. This was the references which I used to study and make my PPT on ultrasound pirates. And this was what I wanted to discuss with you. Thank you very much.